I'm going to just say a few words to welcome you all, and then I'm going to ask Nick to say something before I make some more specific remarks around mental health. So a big welcome to all of you. Just to let you know, I am in Dubai at the moment, and you've all been watching Sky and BBC in the news. So if there are any loud bangs and I disappear, you know why. But I'll be back soon. With that said, let me warmly welcome all of you to today's Coastal Navigators Network workshop. This one on improving mental health outcomes in coastal communities. It's great. We've got a multitude of colleagues joining online from our coastal systems, and around, I believe, around 20 people gathered in person in Thanet who are going to be holding an in-person session after this online workshop. Like I said, it's good to see a number of CNN locations represented, and a special acknowledgement and welcome to our national partners and people who may have joined from central government as well. Now, one part of the CNN and how we work is bringing people together to share learning, to share examples of good practice, and consider how we replicate and scale what works. The focus of today is mental health, because, as we'll hear as we go on this afternoon, that mental health on the coast is not a peripheral issue. It sits right at the centre of resilience, of opportunity, and the future of our coastal communities. I'm going to say it's a real passion of mine, so I'm going to say a few more words about mental health. But before I do, I thought I'll ask Nick just to briefly introduce the network and some background information on it.
Yeah, thanks very much, CAMHS. So I think we've got quite a few colleagues here today who are the SROs, the Senior Responsibility Officers for the Coastal Navigators Network. So hopefully they know about the network and what our goals are. But we also have reached out through the network, through the SROs, to a number of specialists with focus on mental health and prevention. So just some introductions about what the network's about and what it's geared up to do. The originator for the network is the Chris Whitty report from half a decade ago now, where he pinpointed a very urgent national challenge around coastal population health. There's a couple of things going on which are big, and there's a lot of underlying things around this which John will capture. But the big thing is that the demographics have shifted tremendously over the last 100 years. We've got a very different age profile on the coast at the moment. But at the same time, the economic profile of the coast has changed as well. And what that means is that there's a lot of pressure at the moment on services from those with complex needs, some people quite far away from the job market at the moment, and we've got very, very thin infrastructure to deal with it. And it's not going to solve itself. And we've been here before. The reports, the research will not solve it. We need actually a lot of action around it. And that's what the Coastal Navigators Network is looking to focus on, taking the challenges of relatively small communities and make them the priorities at national level. So it's a community of practice, it's a community of organisations which are learning by doing, not learning by researching or admiring the problem, to coin the phrase. The challenges around older people, but this is an intergenerational approach. We will, if we don't deal with the younger people at the same time in supporting the older people, all we're doing is just shifting a very, very big burden of debt onto the coastal communities over time. So we need an intergenerational approach. It's a complex problem, not a complicated one. So whatever we're doing on health needs to be replicated with the economy, transport, infrastructure skills. And that's why looking at mental health is not just around dealing with the demand, it's looking at a lot around prevention as well. So that's why mental health is a really, really popular topic across the network at the moment. And then the final couple of things to mention, it is a network, because if you combine it all together across coastal communities and include the bigger port towns, nearly 1 in 5 of us belong to a coastal community. So it's the equivalent of the north east and northwest region combined. But without a network, they're going to be lost within the mix of ICBs and county population analysis. We really, really need to make Thanet, Fleetwood, all these locations work as a unit to get the messages across and to learn from each other. So this is year 2 of the network. We've already, within the space of 8 months, working with just 6 partners, managed to change the mindset of a lot of national bodies. So we've got commitments at the moment, and years 2 to 5 is actually making sure the national organisations live up to those commitments. So it's a tremendous start, and today is one of the really key opportunities to think about what those commitments should look like. So we're up to 18 locations. Between now and 2027, we want to be working with at least half of coastal population. So we're looking to extend that to 25. And I shall shut up now, and that's the last slide you'll see from me for the rest of today. Thank you.
That must be the shortest slide presentation you've ever done, but anyway, great. So look, as I said, sharing good practice, addressing difficult issues and finding solutions together is exactly what the CMN's about. Mental health is something I've long been engaged with, from being a frontline social worker to setting up and managing services in the third sector, to academic work and publishing, to high-level research, to overseeing several large-scale government programs. And most importantly, I think, or one of the most important ones for me, was serving as the chair of the regulator for all those people detained under the Mental Health Act in our inpatient care units. I did that for a number of years. And it's fair to say, throughout that time, the scale of the challenge has always been significant. But I think it's fair to say that we're now facing some unprecedented pressures. As we know, mental illness now affects roughly a quarter of the population. What is often forgotten is that half of all mental illness begins before the age of 14, right? Before the age of 14, and 3/4 before the age of 25. It's really important figures. We have approximately, I think in 2023, probably similar for 24, over 5 million referrals to mental health services made in a single year, and nearly 1 million children and young people were referred to child and adolescent mental health services in that year, and with nearly 300,000 still waiting for mental health support after referral. But while mental health accounts for around 20% of the burden of disease in the country, it receives less than 9% of the overall health funding. It's about 8.7%, I believe. And demand continues to rise rapidly. And I'll give you one fact. I mean, when I was chair of the Mental Health Act Commission in the late 1990s, early 2000s, like I said, responsible for all patients detained under the Mental Health Act in inpatient care units, the system was already struggling to adjust with a very large reduction in psychiatric beds. Now, if I can give you some figures there, historically, there were around 120,000 NHS mental health beds, inpatient beds in England. Today, that is down to about 17,000 in the NHS and maybe 5,000 or 6,000 in the independent sector. So around 23,000 to 25,000 beds from 120,000. Now, it's important to say that some of that change reflects the right policy direction. I completely agree with it, because over the past 2 decades, we've rightly shifted mental health care away from large institutions and towards treatment in the community. That was always the right direction of travel. The difficulty is that while inpatient capacity has reduced dramatically, the resources needed to begin and build strong community services have not always followed at the same pace. And that matters particularly in coastal communities, because coastal communities are structurally different. As Nick has already said, they often have thinner specialist infrastructure, fewer nearby services, and more fragile labour markets. So when national pressures rise, as they are doing, the coast often feels them first and feels them more sharply. We also need to remember something else, that some people will always require inpatient care. Those with severe psychosis, acute relapse, complex traumas, situations involving serious risk can't always be managed safely outside of hospital. And I think, we've got several inquiries, but one particular one around the recent tragedy in Nottingham with Cal O'Kane. Somebody who murdered 3 people and then injured many others, reminds us how important it is to recognise that the system needs hospital care when it's necessary and responds appropriately. What we're having now is this panic where we're just not sending people into inpatient care, and when they do come in, they're very, very complex. So the message I'm giving, I suppose, is for a functioning mental health system, it must be balanced with strong community services, but also the right level of specialist inpatient care when it's needed. Now that's fairly gloomy, but I think the news is encouraging because mental illness is highly treatable. Evidence suggests that around 80% of mental health conditions can be effectively treated, particularly when they're identified early and supported properly. But if we fail to intervene early, the consequences accumulate across the life course. So many adults who take their own lives, and people I've worked with, have long-standing mental health histories. So youth mental health and adult suicide are not separate problems. They're connected across the life course. And we see the impact more starkly in suicide. And I don't want to steal John's thunder, but it's such a stark figure. In many coastal communities, rates of so-called deaths of despair are estimated around 45 people per 100,000 population, compared with a national figure that's closer to 35 per 100,000. So that gap tells us something important. It tells us that the issues we're discussing today are not abstract policy debates. They are the lived realities in coastal towns across the country. We also know that youth mental health and economic opportunity are closely linked. And we've all heard about what Alan Milburn is doing and highlighting, really importantly, I believe, that you've got nearly 1 million young people are outside of education, employment or training. We're not simply observing a labour market fluctuation. We're witnessing a confidence crisis. For the first time in generations, I think many parents fear that their children may not do better than they did. So that sense of a broken social contract, as it's called, is deeply destabilising. And in coastal communities, where opportunity is already constrained, that anxiety is often multiplied and amplified. If we fail to intervene early, we embed risk rather than reduce it. This is why prevention, particularly early intervention, is so important. And that's why conversations like today matter. Today is about practical learning. It's about understanding what works when local leadership, community partnerships and services align. It's also about learning from places that are already finding new ways to respond. And it's about thinking how we apply those lessons across coastal systems, across all the areas. We'll shortly hear from Fleetwood Thrive. And I think that's a powerful illustration that coastal communities, when empowered and when connected, can redesign systems rather than simply attempt to absorb the demand. We'll also hear about what digital can do. JP, a speaker later, Can Digital, he's going to talk about the potential and scope for using technology and digital tools to enhance engagement. Because ultimately, the question we're addressing today is a simple one. How do we move from managing pressure to redesigning systems that genuinely improve mental health outcomes in coastal communities? hope I've not spoken for too long, but I just wanted to sort of give you a broad spectrum. John is now going to give you some granular context to what I've said. John, hopefully that's helpful, and over to you.
I mean, I want to echo some of the things you pointed out, CAMHS, particularly, and especially why an issue like mental health is so important for the CNN. We're seeing a structural pattern across our coastal towns: narrow labour markets, significant decline in employment, nearly half of working age adults already in the economic inactivity level, much higher rates of lower qualifications, nearly a fifth, or over a fifth in many areas, that no qualifications at all, and others of much lower ones. And we still have an out-migration of talent. The more talented kids leaving, 6 to 10% every year of outflow from our coastal areas. All of that together means that we have not only low employment, but increasing mental health pressures that sit behind that. The structural patterns are actually becoming embedded on coastal areas, part of day-to-day normal life, and that itself is an intergenerational cycle. And we have to think about this in terms of that intergenerational impact, because collectively all of this is leading to increasing sense of despair, disengagement, especially amongst our youth. So this is the pattern we want to break. Just to give some figures locally here from Thanet, you've mentioned some already, CAMHS, but there are significant, if you want to put them all up next, please, the rates of deaths of despair and significantly higher than the national levels. 78% co-occurrence of substance misuse, and here in Thanet locally there's a new, or across Kent there's a new multi-substance service just about set up, we'll be talking about later today. 17% of residents report depression. We know that's an underestimate because this is people actually reporting it. Many don't, of course, so it's significantly higher than that. And again, the levels of hospital admissions for self-harm. So just, this is the statistical reality behind some of that broader context. We have to think about this, though, as a life course issue, beginning with that childhood trauma. Adverse childhood experiences very often more experienced in our coastal areas. Moving into school absence, persistent school absence, emotional distress right from primary school through, and then of course that entry into being neat, not in education and training, leading to long-term economic inactivity, and then adult crisis. So we have to think about this from a prevention aspect across the life course and all the key interventions for that. If we look at it through the employment lens, I think there's sort of 4 critical things we need to get right. That early identification, not through clinical services, it really needs to come from the peer-led model. Really pleased to hear from Fleetwood later today as well, we'll see a really good example of that. Access and engagement that actually addresses stigma, breaks through that traditional sort of service avoidance level. So we've got to get those bits right in order to then have safe routes into work that can build pathways accommodating people's anxiety, their depression, fragile levels of confidence, and extending that further to in-work support and how we actually support people to sustain themselves in the workplace. So it's just sort of one kind of example. And the reason I put that up is because we've got to think about, we've got rising demand, as CAMHS has said, and we've got a thin level of infrastructure in our coastal areas especially. And that means that there's less traditional service input in the area. So it's absolutely essential to think about new models that are tailored for coastal realities and for the situation we've got. And I think some of the core questions for us to consider today is to really support that local information. What do we need at system and national support levels, and how do we take some of the good practice we're about to hear about and scale that and grow it and replicate it right across the network. Thank you, CAMHS.
I'm not going to take questions at the moment. If you can just log them or stick them in the chat box. I'm going to ask Fleetwood and the Thrive project to present, and then we'll have a series of questions on anything I've said, anything John said, and what Thrive has said. So if I can ask the guys from Thrive to present theirs, please.
Yeah,
Mark,
thanks, Kamlesh. Yeah, you've got 3 of us this afternoon. You've got myself, Mark. I'm a GP in Fleetwood. You've got Liz, who is a children's mental health practitioner, and Dave, who is head of one of our primary schools and a school in one of our most challenged areas. And thanks, Kamlesh and John, for outlining the why. Why is this important? And I always start with the why, because when you get stuck in trying to figure out how to make these improvements, keep coming back to the why. Keep coming back to the why. It's been covered, so I won't go over that ground. So what we'll talk about now in the next 5 or 10 minutes, and I haven't got any slides, you'll be pleased to hear, it is more about the how and the what. And like all of your communities, Fleetwood is a very significantly disadvantaged community, very high prevalence rates of adult mental health conditions. For example, the national prevalence rate for adult depression is 10%, ours is 22%. And a significant number of those people can trace the origins of their long-term depression back to childhood. And we started thinking about this about 4 years ago. How do we focus on children's mental health to improve the life of children, but also to then hopefully improve their lives as they become adults? And our starting point 4 years ago was very, very long waits for CAMHS, round about 70 weeks. Our children were waiting for a CAMHS appointment, and our CAMHS clinic was some 16 miles away in Blackpool, which required 2 buses to get there, with very, very high DNA rates in those clinics. In one single calendar year, we had 147 children attending A&E as a consequence of self-harm, which is a dreadful statistic. And also, we've got very low attainment level with our 16-year-olds, educational attainment level with our 16-year-olds leaving school. Only about 20% of them have basic English or maths when they leave. So where are we now, 4 years later? Well, our specialist children's mental health assessments, they're done within 2 weeks of a referral. They're done within a primary care setting, either the GP surgery or their school or our youth hub. Our youth hub, we got a £1.1 million national grant for that, but the hub itself was designed by the children. And what happens in our youth hub is all done because the children ask for that. We also have a fully integrated ADHD autism pathway that's delivered through schools, but with the support of general practice and health. Our CAMHS service is now located into the town and delivers their support from the youth hub, not from a clinical setting. We have input from a consultant paediatric psychiatrist, which very few communities have, but we now have that. We also have a consultant community paediatrician with a specialist in neurodevelopment. We have an MDT in place that supports our most challenged families, where we not only have children with significant mental health and neurodevelopmental disorders, but at least one parent, and that includes alcohol and substance misuse as well. We've recently started alternative provision for those children not in school. So that's run by one of our local charities, and they're supporting and working jointly with school to get those children back into full-time education, and that AP provision is located within our youth hub. We have a volunteer centre that supports young people who are not in work, working in partnership with DWP. About 300 young people under the age of 24 have been supported so far. Around about 160 of those young people are now in full-time education, and around 80 are now in full-time work. We've seen a 54% reduction in CAMHS referrals and a similar reduction in children attending A&E. And as a happy sort of side effect of all of this, we've also seen a 67% reduction in antisocial behaviour across our community. How have we done that? It sounds very simple, but it's one of the hardest things to do, and that's listening to our community. Listening deeply listening, not just a one-off, let's have a meeting and tell our community what we think is good for them. Deeply listening to our community over a period of around 2 years. What is important to our children? What's important to our families? What's important to our schools? And then empowering our children, our families, and our schools to co-design the services that our community thinks are important to them. So that there wasn't necessarily, you know, we need more CAMHS appointments. We need a lot more support coming into schools. We need access to one-to-one counselling, which is now delivered by one of our local charities. We need a safe place. This is what the children are saying. We need a safe place where we can go and get away from county lines that are herding outside our school gates. And everything that we've achieved has pretty much been achieved from within the resources that we already have. So this is health resources, local authority resources, school resources, the voluntary sector, our local charities, all coming together under a single leadership structure to deliver things in a different way, to deliver things that are very schools focused and to deliver things that are very children and family focused. Yes, we've had a little bit of additional resource, about £40,000 a year of additional NHS money. That's all to deliver what we are continuing to deliver. And the NHS has made a commitment to us. They're now funding the Thrive network for the next 5 years. That's the first time we've had recurrent funding in place to do this. I get the privilege of showing off about all of this, but a huge amount of work has been done by Liz, who is on the call, and Liz's leadership has been instrumental in this. So part of the how is empowering brilliant leaders, even though they don't have leader on their badge. Doesn't say, you know, ICB, clinical lead for children's services. I think Liz's badge says Liz. And empowering local leaders. Liz, do you want to come in there and sort of fill in a little bit of the detail?
Yes, I guess briefly, I think what we're finding that why Thrive is successful, because we have truly listened. It's not been tokenistic. We listen. We've not just listened once. We continue to listen because as a network, we meet continually. We never set massive goals. We never set what's your 5-year plan. We don't know. We kind of work in the moment. Everything we do with our community, and that's massive. So we don't do two, we do it with, everything is with our community, with our partners, with our, you know, it's together, it's co-produced, and it's not tokenistic. It truly is co-produced. Everything where I'm sat now has been co-designed by young people. The brilliant ND ADHD free pathway that we've designed has been co-designed with all our partners, so everybody's on board. As Mark said, we've not had a massive resource to do this. We've simply looked at our assets, what our resources are, and we've asked people to not do more, but do things differently and get on board with that. And some people struggle with that, and we've faced resistance. Some of our partners, well, you've asked me to do more. You've asked me to come to this meeting for 2 hours, but actually, if you come to this meeting, there's a full MDT. It's going to save you from going around 9 schools. So they've got on board with it, and it's been a journey. So that the concept was slowly pulling out why it's working, because at first, like, why is it working? Why is this? Why are we 4 years on? And to hear what Mark said, what we've achieved has been great, but we're kind of picking out the concepts of the model, and anything we do forward thinking is such as developing our send off. And now we will use these ingredients such as listening, doing with, you know, using our assets and doing it together and reviewing it, not too forward thinking. It's not led by anybody. We let our network, if someone comes forward from school with an idea, they lead on that. You know, it's kind of just naturally works, you know, and we don't plan too far ahead, I think.
Yeah, the other thing I would say is that the money that comes into Thrive, that money is pooled, and it's a collective decision how that money gets spent. So most of the funding is NHS funding, But most of the funding doesn't get spent on NHS services. It gets spent on things that the Thrive Network want to spend the money on. And a great example is what we call the open table. And that's feeding families. That's families who are not able to have a cooked meal together, either because they can't afford it, or most of our families don't have a dining room table and don't sit down and have a hot meal. So once a week, we have something called the open table, where families, following a referral from school or from the local authority, so it's not a free-for-all, it's our most challenged families, they'll come into the centre, and we will help them to cook a meal. They'll sit down and eat a meal together as a family, and there'll be children's entertainment going on. But we also have statutory services present. We have the local police community officers present. We have children's mental health professionals present to sit and chat with folks in an informal way. And again, brilliant things are now happening from that open table, not only for the children, but the parents are starting to engage more with services that they've really disengaged with previously because they've felt that services haven't done anything from them. And I heard a great story only last week that one of our parents, who has been out of work for about 20 years because of her own mental health problems, went to a job fair a couple of weeks ago and has got a job. The confidence of that lady to go to the job fair, because she's been coming to the open table week in, week out with her family, talking to some of the folks there, and one of the people, Carly from Lancashire County Council, took her to the job fair, and that's now going to have such a huge impact, positive impact on that family now. Dave, from the school's perspective.
Yeah, I mean, I'm kind of slightly smiling to myself because we're making it sound like it's really easy, and it's really not. But anyway, so I'm just going to try and make that picture, my screen a little bit bigger. I think for me, it's relationships and actually communicating, and the fact that, you know, I know everybody not everybody in the NHS, because that's massive, but, you know, I know who to contact within the NHS. I know who to speak to with regards to social services, even, you know, the town council, district council, county council. And I think ultimately what we're talking about is communicating a lot more, sitting around rather than just faceless emails, and building up those relationships over time where we trust one another and we support one another. But we've got this psychological safety to challenge as well. And I think, you know, we don't have, I smiled when Liz said we don't have a 5-year plan. That feels madness to have a 5-year plan. You know, at the minute, my plan's like a week, you know, it's a week plan just to get through this one. And things do keep changing. And I think we're very flexible. We'll move quite quickly. We're not big fans of bureaucracy and paperwork. You know, when we see an opportunity or that something needs to be done, because we've got the relationships in place, we know who to reach out to. We'll move very, very quickly. And Liz and Mark are absolutely right. You know, the fact that we can get our children seen within 2 weeks, we know that Liz is at the end of the phone. And if there's something else that we need to be doing, we've got a system in place where we can feed that back and often now access the funding to make it happen. I feel like we've got a proven track record of making it happen. It's quite exciting. It's a tough place to be at the minute. You know, it's feeling impossible at the minute with the challenges that we have. I've never seen anything like it. But this is kind of one of the shining lights that are hopefully going to help us get through this tough time. Well done, Mark and Liz. I feel like I'm piggybacking on this one. You two have made this happen. It's brilliant. I'm really proud of you both. Well done.
Thank you. I can talk all day if you want me to carry on. But
yeah, he could talk all day. We all could.
Look, I mean, all of you. I mean, that's great. There's some words that jumped out, and you know, deeply listening, co-produce, co-design, single leadership, you know, pooled budgets or pooled decision making. I think that's what the ICBs were set up to do, actually. But anyway, that's another story. But and sorry for using a commercial, but the return on investment, 54 reduction in CAMHS and as much in A&E, 2 weeks assessment. I mean, these are, don't matter the size of the project, these are mind-boggling. This is more than, I think, Liz, you said it was successful. I think it's a little bit more than successful. And what Dave said about relationships and communication, these are all the things that we all say we want to do, but you've done it. Look, so I'm sure there's lots of questions from others as well. Can I go to John and Jackie and see if there's questions in Thanet?
I have one question. The £1 million that you started with, where was that funded from?
Yeah, it came from the Youth Investment Fund.
Okay, which is from DWP or NHS?
No, it's central government funding. CAMHS, you may know more about it than I do. It's central government funding that people can bid against Youth Investment Fund.
Investment Fund, yeah. So, I mean, there's lots of these types of pots everywhere. And you know, I've been party to having these in the past and stuff, and it's what you make of it. So, you know, they'll give you that single £500,000 or £1 million, and then it disappears after 2 years or 3 years or 1 year. And what you've done is used it to create something else. And I think that's the thing we were trying to say is, like, you can't just sink £1 million into an existing system that's broken. And I think what it appears you guys have done is used it very creatively, created that relationship, and then moved to the next bit. So I mean, I think really important. Sorry, Tasmin, you wanted to come in from Kent and Medway?
Yeah, so I just wanted to say, obviously, I'm not in the physical room in Margate today, but I do live in Ramsgate, so I know Thanet like the back of my hand. Hi, sorry, I'm Tamsin. I'm a lived experience lead for NHS Kent and Medway, and my job is basically to make sure that children, young people, parents, carers' voices are heard within the commissioning decisions, which have been doing over the past 4 years. And we've just done a very big piece of work on children's therapeutic services for mental health, where we've awarded a 10-year +3 contract to create some stability in the VCSE sector, and provide that sort of mild to moderate support for children, young people in the community. With my role, I have to do a lot of partnership working, and I completely understand that how hard that is to do across, I know I've popped it in the chat, but where you have sort of VCSE, public health, social care, NHS, local authority, emergency services, I don't think you can't underestimate how difficult that is, because it's like you were saying, like, if it's that whole social economic thing, if a child isn't getting a good meal, how are they going to concentrate at school, and then how are they going to be able to achieve better and thrive in themselves? And there are so many nuances to it, and there's so many complexities, and I think that everybody has this aim, right? They want to partnership work, they want to build a better system, but then there's red tape, there's bureaucracy, there's political issues, there's resistance, and I know you said earlier about that sort of cross-commissioning and pooling money and stuff like that. It's a big question I'm going to ask, so I realise it's here is maybe not supposed to answer all of it, but how did you overcome those challenges that come alongside partnership working, and which were the hardest, would you say, to overcome? Sorry, big question.
Yeah, no, really big question. So how did we achieve this? Dave's mentioned relationships. We have been working in a particular way in Fleetwood for about 10 years. And over those 10 years, those relationships have become stronger and stronger. When COVID hit us 6 years ago-ish, that was enhanced even more. So we've been doing this a long time in a particular way. The other is to keep coming back to the why. Our residents have highlighted the children are our biggest priority and the town's biggest asset. Healthcare professionals were highlighting that children's mental health had suffered, particularly after lockdown. Schools highlighting that children's mental health. But also it was evident that what we were doing wasn't working. So me as a GP, I was regularly being asked by parents to authorise ADHD and autism referrals when that isn't part of what a GP does. Also, having referred a child to CAMHS, we then had to regularly support that family for the next 70 weeks, waiting for that appointment. And so there was and I'm sure Dave will say the same about a dissatisfaction with the status quo. And the great thing about the leaders that we have across the town is this perpetual dissatisfaction with the status quo. We want to rip it up and make things better. The challenges, most of the challenges have been trying to stop people doing to us and telling us what to do. But
to be fair, Mark, and I think it comes across, and I've met you before, so I mean, you, Liz, and Dave, you are probably really good leaders in your own way, and you've brought that lead. This is tough. This is really tough. I've been involved in several big things like this. You really need to push hard. But I think what I say to everybody else is now you can say it works. Look, Thrive have done it with this kind of funding. I'm going to bring Gaynor in a minute, because Gaynor did it in a really tough environment in Clacton with her community group. So I think it does need some charismatic leadership and people, leaders who the community trusts. And I assume just from your personalities, you're trusting people, and I think you've garnered that strength.
Yeah. We are, and I think as leaders, we also pay attention to looking after each other. As leaders, there's always a time when one of us is really struggling, and the others will put an arm around them.
Which is another big point.
Sorry. Yeah. So the only thing I was going to say is that in a way, it's not for everybody. I can think over the 10 years I've been in Fleetwood, where you've tried to pull people in, or people, give the impression that they want to be part of it and they want to make a difference for whatever reason. And often it's just capacity, to be totally honest. I think most people, there's a willingness. It doesn't necessarily work for everybody. I think where we've been pretty good is pulling people in and keeping quite a lot of people in. And sometimes there's a bit of drift and other people leave. If we don't get the right answer from one person, we'll keep going. The three of us, we don't really take no for an answer. But I think we are quite fortunate in time that there's quite a few of us like that. But there has been quite a lot of movement over the years, and you end up, hanging on to people. And it's not for everybody, but there will be people out there who want to get involved and want to make a difference and who do genuinely want to work together. Some people don't.
Yeah. What I'm going to, we could carry on for a couple of hours, I'm sure, and there'll be many people cogitating ideas. I just want to bring JP in to talk about the digital aspect, because that actually provides a little extra layer of help and support, and then we'll have a plenary where we can bring all this back together again. We're not going to move away from what Thrive has done. Lots of questions. JP, do you want to quickly come in and do your piece?
Yes, of course.
Thank you.
Thank you, everyone, for having me along. I was just asked by the Coastal Navigators Network and BBI to talk about scaling early mental health interventions. I work for CAN. We run lots of digital campaigns, and we use the data from those campaigns to reduce cost per outcome. I'll cover a little bit, intervening earlier, how we struggle to understand scale sometimes, give you some search insight, what people are typing into search engines, a bit of a view on mis and disinformation, some approaches that work from across the country. So we've heard from partners that there's a core window when people start exhibiting signs of poor mental health, which if you can intervene as early as possible in that window, you will, for the business case point of view, save between 2 and 10 times the eventual care costs, but more importantly, minimize impact on family and communities. Just to look at the scale side of things, you hear about the brilliant work Thrive are doing, and we see projects all over the UK that have phenomenal co-production, engagement, listening programs in place. But but our brains aren't meant to process scale and numbers, or they're not very good at doing it that well. If you guess how many people are in this heart, just hold a number in your head. There's 1,000 people in that heart. Now, our brains aren't meant to be good at this. In your average primary care network, there'll be more than this. There's 35,000 people in that stadium in Milton Keynes. How confident are we that these programs and these opportunities are being put in front of all the people in those groups that need them? We often hear of brilliant projects that maybe have engaged 3,000 people, which is obviously wonderful news. But when you look at that as a proportion of the total population of a county council, for example, you realise that if we could do more, we could save more negative impact and save the services we work for money. So I wanted to talk about how you might go about understanding the scale that you're dealing with and understanding what people are dealing with and the challenges you might need to face. And that's where data collected by search engines can become really powerful and useful. I'm just going to hop out of these slides for a little bit. This at the moment is UK-wide data. We can zoom in a little bit on some coastal areas, but we can really see here, for example, payday loans, average searches by month, money worries, energy bill, health, bankruptcy. We can start to look at the individual drivers and the things that people are going to Google and other search engines for help with. But we can also look into very specific intersectional challenges like difficulty sleeping, people looking for sleep medication, anxiety, depression, loneliness, and even sort of consumption of drink and drugs. This data shows you over months and years what things stay pretty constant and where we're seeing trends. And so this gives us a sense of the scale, the proportions of what people are experiencing. It's a sort of window into people's minds, but then we can zoom in on very specific areas and get a sense locally what challenges and what sort of volumes we're dealing with. Now, people won't go to use a search engine every time they're experiencing something, so this is not everybody that's doing it, but it's a scaled data set, and it's a relatively live data set. And anyone working with CNN, we're more than happy to create these reports for you for free, so you can get a view of what's going on locally. But that can give you, I think, something which helps you understand maybe how suboptimal pathways are being placed in front of people. When you type in a whole range of problems, you can get information that is either erroneous or designed to extract money from people for things that maybe don't have that much efficacy. So there's this tide of poor information being served to people, whereas what we want to be able to do is to put the sort of optimal intervention in front of people at a very early stage and connect them with trusted pathways that are proven to be able to provide treatment that works at an early stage. So this data can help us understand scale at that regional level, spot trends in comparison to the national, maybe map intersections between financial, mental health and other drivers of poor mental health or other indicators of poor mental health at a local level. I think very importantly, understand the language that people are actually using, moving from the health professional to the words and phrases that people are actually coming and looking for help with, which can help us shape our communications in a way that will actually resonate with them. And then the data can be used to design plans and maybe even build business cases for always on campaigns that basically create intervention engines at the point of need. So I'll now show you some tactics that we've seen working in other places. Often when people are in quite severe mental health crisis, it's very hard to target that online, but what you can do is create information that supports the people around them. Often the people searching may not be suffering themselves, but using messaging that resonates, that lands with people and is designed to help them help others. Works incredibly well, and we've seen it in Scotland. That central creative there was targeted at young people on Snapchat and TikTok. But there's another advantage to this, is that when you talk about people in the third person, it also works back on the first person as well. I'll show you some more data around that ketamine advert, but there are lots of approaches designed to support the community around them, and I think a referral from a friend or family member to an individual that needs care can be much more powerful than just a passive advert, and we're seeing evidence of that in campaigns that we run. This was a campaign, I just quickly put this in now because talking about opportunity amongst young people, run in Milton Keynes on TikTok and Snapchat, where we started by asking them first, do you think there's opportunity for young people in Milton Keynes? It was funded by the Police and Crime Commissioner, triggered by emerging signs of county lines activity. There is no mention of knives, drugs or anything like that in this. It's talking about real stories. This is one for a young unpaid carer, about how they can move towards opportunities and training that help them with the challenges they've got. We're able to measure an increase of about 5% in positivity about opportunity amongst young people. I thought it was very pertinent considering John's initial presentation. This is a campaign in Dorset, and what we're able to do there is target young people, again using Snapchat, maybe people at Bournemouth University, but also across Dorset. They've got people presenting very late down the line with some of the stronger side effects of ketamine usage. And you can see here that we're able to ask people some questions in a sort of online survey and then get them self-referring to services at an earlier stage. And we're now telling stories about what happens through that process and why young people's lives are better having taken some steps, and also how to support friends. So a challenging brief, this one, but something that helps and is proving. You can see that purple line on the bottom, proving that it can increase referrals to the service, whilst also hopefully equipping lots of people to challenge behaviours themselves. This campaign run in Hammersmith and Fulham, targeting mental health, challenging mental health conditions, using principally that search advertising. So when people type in certain terms, ads are placed, connecting them to local charities and VCSOs, James's Place, Andy's Place as well, I think. And here they have seen, those charities and voluntary organisations have seen between a 3 and 10% year-on-year increase in self-referrals from that approach. And Hammersmith and Fulham have now just kept this campaign running, upweighting at times when they know there's increased demand. Another thing that was prompted whilst talking here, this was built for Hertfordshire, which is a list of services designed principally for GPs, but also for other social workers and people that might be able to, might be just helping people navigate the array of services that are there. And we're able then to report on which services are being interacted with most by care professionals to give us a sense of demand. So hopefully there's some examples of what works and what sort of approaches are there to, for very low cost, help us identify, target people at an early stage, and then connect them, triage them through to optimal services at an earlier stage, to augment the brilliant work that that organisations like Thrive and others are doing, but also to deliver that at a scale which means that the vast majority of people are included in it. Back to you, CAMHS.
JP, it's always fascinating. I love this area. And the main word, I think, data. Well, you know, it's really important that we care and we co-design and we work with people. But at the back end, we need this data. We need the trends. We need the scale, because that's what's going to give you the future funding and the proof that doing what you're doing actually has a return on investment and works and creates prevention. AI is going crazy. We need to engage with these things. We can't just simply ignore them happening. It'll make our lives easier. Through this data, we can have heat maps, so we can see what's happening where across your area, your town, your city, your borough, and the trends are, you know, really important. And most importantly, and JP said it, and it's recorded, if you're in the CNN location, this is for free. Questions for either JP or back to Thrive or back to John. We've got 10 minutes to have some more questions. Nick.
I'm not going to ask a question, but I think it'd be really good, given the people we've got on the call today, Catherine from Bridlington, and I think you've got a colleague from East Riding, who are developing a Live Well campus, which I think is aspiring to be very, very much as ambitious and as innovative as Mark and the team's one. So it'd be good to get thoughts upon that, because I know travel is a big issue which you're trying to tackle within your project. And we've got some colleagues from Great Yarmouth which are looking at younger people engaging with schools, particularly more. So I think it'd be really great if we could get perspectives from those particular CNN locations if we've got time. I'm not sure if Catherine, you'd be happy to lead from the Bridlington side.
Fantastic presentation. Sorry, I'm away from the screen now. Obviously, I've spoken to Matt before about Fleetwood and watched the videos, etc. It sounds amazing, and that digital stuff will be absolutely perfect for us. So thank you. But yeah, in terms of Bridlington, we've realised that there's the half compass effect is amplified by the fact that we're on a border of 2 different NHS trusts. So all our services have been dragged away, sort of up to an hour, 2 hours away, to the extent that people are going for scans with full bladders and wetting themselves on the way, so that hospitals are having spare clothes for people. So it's a pretty dire situation. So we've set up a community lift scheme whereby people will be taken by volunteers in their own cars to health provision, but you know, which is a really good thing. We're happy to have been able to do that. But I think collectively, I'm sort of been nagging at the CNN to try and sort out the healthcare travel cost reimbursement scheme nationally. I don't know if this is something that CAMHS you've looked into, because the scheme's appalling. You have to pay in advance for a taxi, for a bus, etc., which costs a lot more than people can afford. You then have to wait weeks to try and get the reimbursement back. You have to go to cash desk in hospitals which don't exist anymore. You have to fill out a 6-page form to do so. So I think in terms of health inequalities on the coast, it's an absolutely massive issue, and one the NHS should be tackling much better. And the funding is there; it's just not accessible. I don't know if anybody else has had this sort of issue.
Just to say before, if we can take that offline, Nick, I think it's really important, especially for a lot of the coastal communities having this. I think really important. But happy to sort of see what we can, to raise the profile of this. I don't know if it's the same issue with Thrive as well.
Well, the thing about travel, I suppose, for any coastal network, is our residents won't travel. They won't leave the town. So it's not only access to healthcare, it's access to education. Our post-16 education, again, was sited in Blackpool, 2 buses away. So bringing post-16 education into the town was something our community asked for. And so that's what we've done. More and more services, as you said, Catherine, about Bridlington, more and more of our services are being located further and further and further away. And one of our challenges is bringing them back. But one by one.
Great Yarmouth.
I'm here from Great Yarmouth. Yeah, I'm not the
Great.
SRO on the project, but I mean that sounds really good. Like listening to some of the Thrive stuff that's been happening, and it's just in my head as you're talking through. I'm kind of thinking of opportunities that we may have in Great Yarmouth to try and kind of support the system with some of that stuff. We've got the DWP youth hubs, which are starting to be developed through, which could provide kind of an opportunity for some of this thing. We've got some money that's come through the health and wellbeing partnerships from public health, and kind of one of the things we've worked on in the last year is something called Eat Well and Thrive, which was about supporting communities and kind of specific neighbourhoods to kind of reduce or promote healthy weights and reduce obesity. And just think that that's been kind of like a through the life journey angle as well. So not targeting kind of older people or younger people, but these all kind of provide some opportunities where we could kind of try and embed some of this learning too. And we're also running in a particular area in Great Yarmouth this year, something tackling antisocial behaviour, which is a clear hold build project. And again, kind of looking at some of the outcomes from the Thrive project, I think that looks really, really good. And I think there's definitely some learning that we could have from that.
Super, thanks, Dean. Gaynor, I saw you earlier. Gaynor runs a phenomenal service in Clacton. I don't know if you've got some views, Gaynor.
Yeah,
done an amazing, yeah.
Thank you, CAMHS. Yeah, so we're a charity based in Clacton-on-Sea, so clearly a coastal charity, yeah, with lots of different issues that we have. It was really fantastic to listen to you, and particularly listen to you, Liz, about Thrive. We're absolutely passionate about co-production and collaboration. And we hear so many times that people co-produce, but we know they don't, they just consult. And it is about the listening. I think listening to people really well is undervalued. I always say I love data too, but I think people's voices are the data with soul. And it's really important that we listen and hear them. And also those voices where people have had really difficult journeys, you know, that sometimes statutory services might say challenging, difficult. We call them seldom heard. And we understand there's no such thing as difficult people, that people have had difficult lives. I think the real success in these services and what we're doing at the moment is that we have absolutely co-designed some services for people locally. We've been really fortunate. We've set up our own Coastal Lives Foundation, which gives us a level of autonomy. And the projects that we've actually developed with local people are very different, creative. So we've been able to fund things like for people like sobriety coaches. So it's addressing the issue of people that are grey drinkers that start very, very young, but for them kind of places like AA may not be, they're fantastic, but not the right platform for them. We've also been able to design by them, set up a project called Grow Wild, which is an outside space where families work together. They grow things from seed. They have access to outside. What they grow then goes onto the local community table. So it gives people who are in food poverty a meal and goes into a community shop as well. And this is only possible because of listening. And listening some more. And I think really that needs to be the solution moving forward. And it's those kind of voices and people who are the experts. Even the Care Act says that people best know about what those services should be and what can best meet their needs. So that was absolutely fantastic. I think for us moving forward, what we've learned is, yeah, the definition of insanity is keep doing the same thing time and time again and expecting a different result. We need to be challenging that system, and we need to use local voices in order to do it, and they need to be leading, not us. We need to make our community leaders. So it's brilliant. We know for us in Essex, we've got tough times ahead. We've got local government reform. We've got a whole lot of dismantling of services going, and we just need to be thinking differently and doing things differently, but being led by our local people. Yeah, but fabulous to hear. Amazing to be here today.
You can all see why I asked Gaynor to come in there, because I knew there'd be some pearls of wisdom, and they are. Sensible, common sense stuff that for some reason we don't do. Look, today is just a brief example. A couple of projects, and look at what they've achieved. Now we've got 18 locations. We're hoping to get to 25 locations. If we can get 20 areas with similar ideas working together, that scale, that's when we start having impact. And people might say this is not possible. It's absolutely possible. Jez, John, Claire, myself, we were lucky. We worked in the old days when money was available. We managed to do this on a large scale with mental health services and with drug services, drug and alcohol services. And we connected hundreds of locations. And we did what Gaynor said, the communities and the people were in charge. And we were able to give some resources to them. And we changed government policy. We genuinely changed government policy because instead of having fantastic researchers, we had the community. We did a small scale trial in Gaynor's service. And what comes out is fantastic. And they're the leaders, they're the true leaders that do this. Our job is to make sure their voices are heard at all the levels, at local level, regional and at national level. And I think as a CNN network, we can pull this together, we can get the evidence with, JP's digital background, we can get the evidence, we can show if you invest in these things, you can deliver large scale results. We can reduce that A&E attendance by 50% across all those areas if we do the right thing together. So hopefully you've got a flavour of what the CNN network does. We do a lot of these workshops, and I think hopefully people will go away and learn something. So Mark, you might be able to take away Gaynor's idea of growing your own vegetables in the allotment and put it on just that one thing. If you've learned and done, that's fantastic. And like I said, JP is going to be available to all our networks. I'm very conscious we could carry on a lot more, but I know the people at Thanet have got a in-person workshop to take this forward and come up with some wonderful ideas. John, Jack, is anything from the group there, because I can't see them all? Is there any particular issues before we sort of bring this to a close?
It was really inspiring to hear all of those, and while you were talking, I was just looking at where you were, where on the coast it was, and it was interesting to see that. One of the things that came into my mind that when you were talking about empowering communities, that's the bit that got me the most, actually. I thought that was really interesting. I live in a really posh bit of Kent, probably the poshest bit. And the other night, the Royal Society of Arts organised an event to get local people to talk about environmental issues. About 30 people turned up, and afterwards they all were ignited, and they thought, right, okay, we're going to do transition towns, we're going to have a WhatsApp group, we're going to have resilience for this. And so, it was an empowering thing. What I noticed is that for so-called disempowered communities, for poor communities, what we're really talking about here, isn't it? Their voices don't get the same amount of respect. So it's all very well for Tunbridge Wells people to come together in a nice articulate way and say, oh yes, here we are, we're going to do this now. They didn't have any money, they just decided to do stuff. And the other day I met with the mental health user organisation group in Thanet, and one of the things they were saying to us, we've been saying the same thing for years and years and years. We've got voices, we've got things to say. I did invite them today, they're just going to make it really busy. But they want to be here, they want to say stuff. But it's, we just need to move it away from being patronising, I think. That's what I'm trying to say really openly. And actually, because they're not posh like people from Tunbridge Wells. They still know stuff, and they can still get stuff done. And that's just how it's. So, do they need community development? Do they need community empowerment? Do they need just to tell us so we do it? Do you know what I mean? So I think that's, for me, that was an important thing.
Thank you, Jez. I mean, that's really helpful. I mean, it's simple and complex at the same time. You know, professionals don't want to give away their so-called power to the people that matter, in a sense, and listen to what the lived experience is. And I think that's a big shift. We all talk about co-production and co-design, but we genuinely have to co-produce and co-design. That takes a shift, a mind shift in people's minds sometimes, because I always know better because I am. No, I think that's one lesson we take away today with this. But look, we've got really good example. We'll be pulling these together. We'll be taking it forward. We'll be writing all this up as we always do. But I'm really excited in terms of growing this network and getting some, you know, improving the lives for local people, but actually getting enough data and strength and voice that we can take further up the chain and say, this simple solution here that will cost half as much as what you're spending in, or a quarter of as much as what you're spending in A&E, we can solve. And we genuinely can, and I think we've seen that. Look, thank you, all of you, so much. Sorry it's been a bit rushed. I think there's lots to talk about. Hopefully, I'll get back to the UK one day and look forward to seeing you all. But in the meantime, stay safe and see you again soon.